Hi everyone, it's a pleasure to be here today and present my latest work at the EASD 2021 annual meeting. I am Naba Al-Sari, final year PhD candidate from Steno Diabetes Center Copenhagen in Denmark. Can we predict future microvascular complications such as diabetes retinopathy and diabetes kidney disease in type 1 diabetes using artificial intelligence? This is the title of my presentation today, and the answer is yes. The diabetes complications we looked at in this study were diabetes retinopathy and diabetes kidney disease. These are both very common microvascular complications in individuals with long-standing diabetes duration, and it decreased their life quality. The best way of helping these patients is to perform early detections and diagnosis of the disease progression. So how do we do that? The answer here is with personalized medicine. I have developed and trained an artificial intelligence algorithm that can predict the future progression of each of these diabetes complications from a large type 1 diabetes cohort, and I called the algorithm for Diabetes Pro. In this study, we had registered information about progression on diabetes complications from 537 individuals with diabetes retinopathy and diabetes kidney disease. The median follow-up was 5.4 years. I had 17 baseline clinical risk factors and 965 blood small molecules or lipid species and metabolites measured by the baseline blood samples on mass spectrometry. The next step we did was classifying the participants into two groups, type 1 diabetes stable and type 1 diabetes with progression to diabetes complications. We had some exclusion criteria for the stable group. We excluded participants who had reached the end-stage complication at baseline, such as those with severe retinopathy and or were blind and microalbuminuria. Then we predicted the progression to diabetes retinopathy and kidney disease in two additional complication-specific models. Prediction models were all fitted first on clinical risk factors only, and then on clinical risk factors plus blood small molecule data. So I had 6 models in total. Today, due to the limited time, I will focus on the best results, the prediction model for the 30% decline in eGFR with the full dataset. Here you can see a brief description behind the machine learning algorithm I have developed in a simplified way. So the first step I did was to test a few different machine learning algorithms and went with the one who provide the best results. In my case, random forest algorithm was the best choice for this cohort. The second step was splitting the data. So I used 80% for developing and testing the prediction models, and 20% I saved as unseen data to actually validate the algorithms. The splitting phase was done randomly and with 5-time cross-validation. Then, as I said earlier, step number 3, the training set is for model development and test set is to validate the performance of the trained algorithms. Now, ideally, you will validate in a completely new similar cohort, but it can be a bit tricky here. I will come back to it in the end of this presentation. I used the SHAP algorithm for future elimination and future importance. And finally, to validate the performance of the algorithm, I looked at the performance measurements such as accuracy, precision, recall, F1 score, and AUC. As you can see here, The performance of the diabetes PROC AI algorithm looks very promising and with high accuracy. The final prediction model for diabetes kidney disease progression was obtained by combining 4 clinical variables and 6 metabolites. You can see this in the SHAP summary plot, figure A. This panel of clinical risk factors and the small molecules on the y-axis contributed most to the prediction, and variables are ranked in the descending order. The x-axis shows whether the effect of that value is associated with a higher or lower prediction. The dots are original values. Color shows whether that variable is high in red or low in blue for that observation. For example, a high level of the albuminuria or mild degree of retinopathy have high and positive impact on the progression of the kidney disease. The high comes from the red color, and the positive impact is shown on the x-axis. Similarly, I will say EGFR is negatively correlated with the kidney disease progression. The panel of these of the small molecules looks promising for me. Ribonic acid, ribitol, and myoisotinol. All these metabolites, the elevated levels of them have been addressed in previous studies to be associated with other diabetes complications, such as diabetes neuropathy, and in type 2 diabetes with higher risk of end-stage renal disease. But there's no data on the direct association between the hydroxyl fatty acid and diabetes complications or type 1 diabetes. We know that from several other studies that retinopathy is associated with nephropathy. Retinopathy was one of the top 3 important variables for predicting future diabetes kidney disease here, which is in line with previous studies, confirming that the machine learning algorithm here is able to reproduce known risk factors. And in figure B, the model excellent performance with the mean AUC 0.99. The future goal with this kind of algorithms is, of course, to implement it in the clinic and help clinicians with individual risk predictions, exactly as I am showing here 2 examples from the real data. In this example, I am showing 2 individuals correctly predicted as type 1 diabetes stable individual without progression to diabetes complications with a probability of 0.02, and an individual with diabetes kidney disease correctly predicted by the model with a probability of 0.84. Also, I should mention here, these 2 individuals were predicted from the models using only clinical variables. So the evidence from this study also shows that the prediction models based on variables routinely collected in the clinic can be excellent predictors for individualized prognosis. To summarize results from this study, machine learned algorithms using traditional risk factors predicted the future progression of diabetes complications in type 1 diabetes with promising results, and inclusions of small molecules data further improved the predictions. Thank you for your attention.